Okay, well, it's getting a little bit late, so I have a feeling that we might have a lot to hear in the next with this talk. So I'd like to get started. So it gives me great pleasure to introduce Dr. M.Shuch, who'll be talking about the update on management of localized renal tumors. So Brian joined the Yale Department of Urology in 2013. It's just a few years. It seems like a while longer than that, given all the interactions we've had. He obtained his medical degree at New York University in 2004, and then did a urology residency at UCLA 2005 to 2010. This was followed by a 3-year urologic oncology fellowship at the National Cancer Institute, where I know he did a lot of interdisciplinary work, from what he tells me, including with interventional radiologist Brad Wood down there. He came to Yale, recruited with a particular interest in urologic cancer, obviously, especially kidney cancer, and this includes hereditary kidney cancers, where he has really, I think, raised the bar, advanced the care here at Yale, and it created several, or helped to beef up several programs. And this includes his role as a director of the GU Cancer Biospecimen Repository, director of the GU Cancer Genetics and Prevention Program, and he also clearly has several grants now directed studying the biology of renal tumors, from genetics to immunohistochemistry, as well as the treatment. I personally had many interactions, and it's been a real pleasure. It's very collegial, and has taught me a lot during the past few years. So it really gives me a great deal of pleasure to introduce Dr. M.Shuch, and I look forward to hearing his comments on localized renal tumors.
Okay.
Thank you.
Okay, thank you for having me. I'm going to give kind of an overview on where we are today, 2018, kind of state of the art, where the field is moving, and also kind of touch and highlight some of the expanding roles of kind of the interventional radiologist in the care of patients with localized and also maybe advanced disease. We're just a brief outline where we're going to go, and if there's any questions, we make this interactive. Any comments, please just let me know. So what is kidney cancer? That's just a really bad slang term. It's not really descriptive. So what we know is, 95% are what we call renal cell cancers. About 5% do refer to transitional or urothelial cancers. And the burden is continuing to increase. It's now 65,000 cases a year of renal cell carcinoma. That doesn't account for ones that are maybe the benign oncocytoma or the fat poor angiomyolipoma, but about 1 to 2% of individuals get kidney cancer in their lifetime. And on the population level, this is a little old, it hasn't changed that much, is that kidney and renal pelvis cancer in men and women, number 6 and number 8, but in number of deaths, it's number 10 and number 11. So it is a source of major morbidity and mortality in the United States. But things have changed over the past 30, 40 years. The incidence of kidney cancer has actually doubled or tripled, but the number of deaths each year has stayed exactly the same, about 12 to 14,000. And what epidemiologists show is that this is a pattern similar with PSA testing and prostate cancer. You are basically over-diagnosing patients. And the problem here is you're also over-treating a lot of patients as well. And we know that patients who have treatment for, let's say, prostate cancer, it's immediately noticeable whether they have impotence or incontinence. But for kidney tumors, some of the changes, such as silent changes in your GFR, may manifest themselves many years later. So this is a continuing issue in our field of overtreatment. And why is this happening? Why do we find more tumors? Well, as you know, that people come to the ER physicians, if someone coughs and they order a PAM scan them. Seen people get found with renal tumors. My favorite story is a woman got bit by a spider. She had a panic attack. She had some chest pain. They scanned her and they found a 1 centimeter renal mass, and then she had more anxiety, and it kept on going. But basically, the availability of cross-sectional imaging studies does lead to, obviously increased cost, maybe also increased radiation exposure, and also these incidentally detected cancers, which is a problem when you, have a patient who's 400 pounds and they're worried about their 1 centimeter renal mass. So it's led to a total change in the pattern of detection. In the 1980s or earlier, these were called the internist tumor. You had patients who had this classic triad of flank pain, abdominal mass, and hematuria. But we had patients who presented with these more subtle signs, such as fevers, cough, high calcium. They could have a high blood count. These tumors can secrete epogen. Elevated liver test is an interesting thing called Stauffer syndrome, a transaminitis due to inflammation, or peripheral edema due to a tumor thrombus blocking off their blood supply or venous return. But after 1980s, when we had this massive expansion of incidentally found tumors, over 50 to 70% of tumors now are really found accidentally. But we still see these patients who have these paraneoplastic syndrome. This is a patient we operated on last week that was coming in with malaise, was kind of bedbound, was having a chronic kind of chills and fevers, and he was found with this about 12-centimeter renal mass invading into his adrenal gland with no other evidence of metastatic disease. We removed this robotically about a week or two ago, and he's now, all those symptoms have resolved. So it's really the tumor that is causing these symptoms, which is really interesting. But as we find more kidney tumors, are we finding more of these giant masses accidentally, or we're finding small ones? So if you look at the pattern of detection, over time, the incidence, it's really, we're finding more and more of these 2 to 4 centimeter renal masses, which are kind of the ones where you're not sure what you're going to do with it. It's clearly different when you find it in a 90-year-old person versus in a 45-year-old person. So who gets kidney cancer? We're going to touch upon my area of interest. But, male sex, men get it twice as common as women. Those who are obese, there's a graded risk. Hypertension, smoking, slight increased risk. Chronic kidney disease or dialysis. Dialysis and even transplant, the risk is so high, it's about 20 to 50-fold higher than the general population. I argue that all patients who are getting transplants, they should get screening of their native kidneys periodically, but it hasn't really made its way to an agreement. And then hereditary risk factors. So if you're seeing a patient who has a kidney tumor, always think maybe genetics. It was long thought that only 1 or 2% of patients who had a kidney tumor really had a hereditary component. But in reality, there's probably about 5 to 8%, maybe as high as 10%, that have a really strong genetic component. And I always ask my patients, what did their fifth cousin die of? They have no idea. But if you look back to ancestry studies from Finland and the Scandinavian countries, they can track their relatives back about to the 13th century. And it turns out that 80% of kidney cancer is really clustered in 20% of the population. If you have a third-degree relative who has kidney cancer, your risk is actually 1.6-fold higher than the general population. But there are well-characterized syndromes that people have heard about. VHL, which is one of the classic syndromes, which multiple different tumors in multiple areas. Birt-Hogg-Dubé, HLRCC, hereditary papillary. But there's a whole host of new genes that are associated with syndromes, and we see these patients here. We do a lot of genetic testing. And basically, each of these differ slightly based on how common kidney tumors are, where the genes are located, what other manifestations patients have. But we see these patients, and they're actually, these things are more common than described. Like VHL is told in the literature is 1 in 35,000. You could take these large exome databases in the general population or 1,000 genomes. It's actually probably about 1 in 5 to 1 in 10,000, so 3-fold higher. And that's because we're probably pretty poor at detecting it. So if you see a scan, you see someone with a couple pancreatic cysts and you see a couple kidney cysts and tumors, it doesn't hurt to say, if there's any clinical suspicion, consider one of these possibilities. And, we actually get this, your thoracic radiologists are pretty good when they see a kidney tumor and they see a couple lung spots. We have plenty of patients here who have tuberous sclerosis that have lymphangiomyomatosis, or we have about, 20 families with Birt-Hogg-Dubé. And it's something which, when you see it, you remember that there are these kind of conditions, and if a clinician is not astute, they really rely on someone who's paying attention to these characteristics. But who should kind of get considered for these conditions? Well, we have, if you have early age of onset, the average age of kidney cancer is 64. So if you're seeing a scan or seeing a patient who's 42, clearly that's a little bit abnormal. If you have bilateral, multifocal, tumors, that's clearly kind of not normal. Only 1 to 2% of people have been thought to have bilaterality. Strong family history, and if you have, other things like lung cyst or pneumothorax, or other skin findings, there are a couple different findings that manifest itself either on the face, the hands, or the trunks. We see those, or anyone who has a family history of maybe having any of these conditions. So if you see a scan like this, you see bilateral, multifocal. Clearly, this should raise suspicion that it's not something straightforward going on. And this patient actually had was 25, so it was early onset, and he had Birt-Hogg-Dubé syndrome. So the AUA kind of changed their guidelines based on a paper I was involved with where we looked at the hereditary cancer experience at the NCI. And if you looked at all the patients with all the syndromes, and a lot of these patients get flown in on your taxpayer dollar to the NIH to get evaluated, the average age of patients with hereditary forms of kidney cancer is 37. And the average age in the general population is 64. If you put these together, you see that there obviously is some overlap, but trying to decide who should get tested or at least counseled, if you have someone age 46 or less, and you kind of set the cutoff there, you might need the number needed to test to find something, might be less than 1 in 10, which is considered acceptable. So anyone less than 46 should be at least raise the possibility of having something genetic. And how do you see a patient, you can get them referred in for genetic testing. The way we used to do it is you had someone come in, you test one gene, they come back 3 months later, it's negative, you test another gene, come back 3 months later, it's negative. So it took a long time, and you would sometimes not get a diagnosis. Now we have these parallel or shotgun panels. You see someone with pheo or paraganglioma, you test them with 10 genes. Kidney tumor, 15 genes. If you have breast cancer, you test those 15 genes. And we're doing some stuff when we have patients who have really unique phenotypes. Well, why can't they have a new condition which has never been diagnosed before? And you can do really germline exome sequencing, look at your panel of your known genes, and then expand outside that panel to find some interesting kind of phenotypes. So what's the state-of-the-art workup for the renal mass? So I try to tell everyone, a non-con CT scan, I would tell everyone, is worthless. It shows the deformity of the shape of the kidney, but we miss things all the time. Understanding the renal ultrasound, I think, is also pretty worthless. It shows hyper or hypoechoic areas. It's nice to see some flow in a lesion, but if the probe is moving and the tech doesn't do it perfectly, maybe you say it has vascular flow. But I also think the CT scan without a non-contrast phase is a temptress. It's something which you shouldn't take someone to treatment based on that. And we've seen it's very suggestive, but a lot of times, even when we see the report, sometimes on the outside, frequently not here, it says renal cell carcinoma. But we've seen a lot of mimics, and these are ones we see often, and we go to the reading room and bug you guys, but hemorrhagic or hyperdense cyst. We've seen plenty of focal pyelonephritis or infarcts that have some, that could look kind of hyperdense. We've seen some areas I've seen splenorenal fusion twice, metastases obviously, but we don't try to treat unless we really have a good quality scan with and without contrast. When it's gigantic and there's a tumor thrombus, clearly you know what it's going to be, but especially these small renal masses, you don't want to be caught in the OR searching for a tumor. And during fellowship, we had a couple of cases where people went to the OR and then they were ultrasounding and they couldn't find anything. It's not very satisfying when they have a patient under anesthesia and they've been under surgery for 2 hours and they don't find a tumor. And the radiologist said, it probably was just a focal pyelo. So it's not very satisfying. So I think, really with and without contrast is really mandatory. And both, I think, MRI or CT are excellent. The reason why most urologists or other people don't order MRIs, I think my colleagues don't really know how to read them. And when they take someone to the OR, they look at a million images and they're all confused. I personally like MRI better because I think you can really delineate the soft tissue structures better. And Stefan here helped us kind of work and define a really nice protocol with DWI and DCE for kind of research purposes. But obviously a lot of people make excuses why they shouldn't order it. The patient has a pacemaker. We bug Jeff and Gary all the time, and most of these pacemakers are MRI compatible. Now with Dotarum, we can can get the contrast well. And when we're trying to evaluate patients, we look at a lot of things, obviously the size, the cystic components, the number of lesions, we look at laterality, and really the enhancement. And sometimes these cases of borderline enhancement are confusing, and I think what's interesting now is the radiology department now has the capability of doing contrast-enhanced ultrasound, which I think is going to be a nifty tool for these kind of equivocal cases. And then, of course, also how complex are these tumors? And obviously, the advanced cases, are there any involvement in the collecting system, renal vein, adrenal gland, et cetera? And then the nodes. Are these nodes, we see periportal nodes all the time in people who are alcoholics or hepatitis, but people get referred into us with locally advanced kidney cancer saying, oh, what do you want to do with this node-positive person? And, you see those nodes around the portal vein and often, and generally it's not too concerning. So we have a system called the renal score, or the nephrometry system. There are a couple different ones where you take in nifty acronym. You have the radius, the exo or endophytics, the nearness to the collecting system, and how it is related to the polar lines. This is related to, there's a higher risk of complications after surgery, but the Mayo group has done a lot showing there's a higher risk of complications even after ablative procedures, and also a higher rate of recurrence, even if you remove things like the radius. So clearly, if you have a tumor deep in the sinus, it may not maybe be killed as well as something very peripheral, where if you're going to ablate it, you're less worried about maybe a heat sink effect. And basically, we just come up with a scoring system. And when you say, oh, I ablated, this is my series of tumors I ablated versus that guy, or I did these partials on these tumors, clearly you need some type of system to kind of say how complex the system is. Obviously, if someone is treating 5-centimeter T1B tumors, it's going to have a different outcome than a whole people who are treating a couple 1-centimeter small ditzels, which probably didn't need to be treated. And clearly, we also use the Bosniak classification system. We run and try to ask about complexity, and it's amazing that even today in 2018, we kind of get a lot of radiology reports on the outside, and they just say complex renal cyst. And then we're left kind of worrying what to do, and it's unfortunate. But in the past, we used to just say Bosniak 1 and 2, leave alone, never focus on again. Then this 2F category came in to follow, and sometimes the reports still say Bosniak 3 or 4 are surgical lesions. I follow tons of patients with Bosniak 3 and 4s. There's a paper we worked with the radiologist at Mississippi, Andrew Smith. We looked at cost effectiveness of treating Bosniak 3s versus doing surveillance on them. And it's probably more cost effective and less harmful to do surveillance on these Bosniak 3 lesions. So this is just, a patient, these tumors can be aggressive even if they are, a Bosniak 4, and this is just one that, we ended up treating, and it was kind of a high-grade tumor deep in the sinus. So then how do you follow these patients for workup if you're seeing someone in the radiology clinic considering ablating, or in the urology clinic? Low-risk patients, we want to just look at their chest. Just a chest x-ray is fine. The importance, if something was metastatic, you want to kind of, understand that before treating them. If someone is going to have, general anesthesia, if someone is going to be a hard ablation and you think they're going to move and you want to put them asleep, you probably want to know how their lungs are for the anesthesiologist. But when you're seeing a high-risk patient, if you're going to be treating someone with, a T2 or 7-centimeter tumor or greater, or a a tumor that looks really ugly, it doesn't hurt to image their chest with a chest CT. And the reason why is because obviously you find these intermediate nodules, but when you scan someone a year later and they have a couple 5-millimeter, 8-millimeter lung nodules, it's nice to kind of know, do they have metastatic disease? And the way to know is to kind of see things serially over time. And here's just an example of a patient who had a low-risk tumor. It was about 4 centimeters, and there's a nice kind of lung nodule over here. And remember, patients who are old enough to get kidney cancer, generally are also old enough and have enough risk factors to get other cancers. And this was a non-small cell lung cancer, and she ended up having this kind of taken out, and she had some mediastinal nodes, and then we didn't touch the kidney tumor for another year or two. Because most of these kidney tumors are not as aggressive as lung cancer. And then what to do for the kind of other workup, we don't like to necessarily order bone scans. For prostate cancer, it's osteoblastic. You can see things. For things like kidney cancer, it's mostly osteolytic. You can see most of these lesions on cross-sectional imaging. If you have a patient with, and there's unexplained hypercalcemia, high alk phos or bone pain, you would consider ordering that study as well. Brain imaging, if someone has confusion or seizures, clearly, they need to get further workup. But if someone doesn't have any disease anywhere else in their body, we've looked at our kind of series here, and I did a project before, having a brain, of the patients who have brain metastasis, only about 2 to 5% really have isolated brain involvement. So it's not worth the kind of expense ordering that test. And a PET scan, it's really limited. You have patients with documented metastatic disease. We could biopsy it and we image it. It's not effective at showing. The sensitivity is pretty poor. It's not approved by insurance, but Medicare often pays for it, for government insurance. There are emerging areas. We have a paper that looked at these rare hereditary forms of tumors that are characterized by the Krebs cycle deficiency, and those have a lot of glycolysis. For something like that, it's very useful, but for the bread and butter kidney tumor, it's not very effective. And a lot of people in the community order it and say, oh, I don't need a really high-resolution chest CT. I'll just get a PET CT. Well, maybe that's fine, but as you know, it's not as good as looking at the chest is probably a good high-quality study. And I think the MRI, I like it personally, but obviously if something's funny in the liver, we like to get it. And then the other thing is when we have tumors that are in the vena cava, it's nice to kind of know the level. I think, CT and MRI are very useful. If it's kind of really close to the diaphragm, sometimes we get an echo, because sometimes we need a cardiac surgeon to put some of these patients on bypass to kind of get these tumors when they're moving up high. So when you see a patient and you try to evaluate them, you say, their creatinine is great, they're going to be fine. Well, it's not all about creatinine or EGFR. There's now kind of different algorithms where you need to assess not just their GFR, but also their proteinuria. So if you see a patient who has a 2.5 centimeter renal mass that's deep, and you're going to have to treat that with surgery or ablation, but they also have the ability to have active surveillance, always have to recognize that what treatment you do, your kidney function is not going to get better after any treatment you do. So if the person has perfect, creatinine of 1, but they have high proteinuria, you need a caution that they're going to potentially have functional decline for the next 5, 10, 20 years. So I would say, any time we see a patient who is in this red area, clearly low GFR, we have to worry. But even the patient with good creatinine and they have some protein, and it's just a single one-time lab test, they have their urine, you send it for creatinine albumin ratio, and if they have proteinuria, it's something to worry about. And just looking at patients who got kidney cancer treatment, the ones who have the bad risk group, they do have functional decline in their renal function pretty significantly. So having protein leads to worse outcomes and worse functional outcomes as well. With kidney cancer treatment, the same as what you'd expect in the general population. So the AUA recently changed their guidelines to say, hey, anytime someone has any procedure done on their kidney, we should really explain what the kidney does, the importance of it, understand that, if certain people have risk factors for progression, you really need to counsel them. We don't want people 5, 10, 15 years later to come back and say, hey, I'm on dialysis. I had no idea that, treating this, taking this kidney out 20 years ago is really going to have any implications. So if you see a patient, you always consider referral to nephrology for certain things, like having a low GFR at baseline. If you have some proteinuria and you're worried about maybe functional deterioration moving forward, and diabetes and pre-existing chronic kidney disease, and whenever your expected EGFR is going to be less than 30 after treatment. So I think, you can always say, the referring doctor is going to do it, but as a treating interventional radiologist, sometimes the person sending patients to you may not be that smart or up to date with the literature. Now, what's the role of the renal mass biopsy? So the AUA, the American Urologic Association, our urologic governing body, they basically says, patients should get counseled regarding, the benefits, the false positives, the false negatives, the potential risks, and non-diagnostic rates. We believe seeding is negligible for kidney cancer. There's 1 or 2 case reports in the literature of people, having, biopsy done. So I would say we think it's very safe. We feel that the rate of significant renal hematoma is very low. Great, you can image after the biopsy. You can show a little minor hemorrhage around the kidney, but the rate of actually getting transfused, I don't know. Doug, have you ever transfused a patient for a renal mass biopsy?
Yes.
It's probably less than 1 in 100.
It's pretty rare.
Yeah. So, but patients, so urologists still have this perception, oh, you're going to spread the tumor, you're going to cause bleeding. I think it's safer than probably the patients who have chronic kidney disease, who have some uremia. But, damage to adjacent organs is very low. But the sensitivity is pretty good, but there are patients who have a non-diagnostic. Sometimes some tumors, just the characteristic of them, you're not able to get good meat, or the architecture is not very good. So there's about a 15% non-diagnostic rate. The problem we have is this oncocytic neoplasm where the tumor looks pink, you're not sure what it is, but don't be afraid to try it again. So we have plenty of patients who have a non-diagnostic biopsy. I try to get them biopsied again if I really feel like it's going to change management. And that's one, this series from Toronto where they looked at the non-diagnostic biopsies. A lot of them was just normal kidney. And you think, this is probably going to be the endophytic tumors where you don't have much good landmarks. Try again, give contrast. Or potentially do it under, have the ultrasound available as well. Make sure your needle's in the area. But the insufficient tissue is also something. But the 80% of the patients who have a non-diagnostic biopsy, when you re-biopsy, most of them get a diagnostic biopsy. So the AUA does really say these should not be biopsied. And I would say, you guys, if you have someone who gets referred for a biopsy, don't be afraid to, say, well, this, shouldn't be done. If it will not change management, if the patient is saying, I don't care what it is, I'm still going to have to get treated. So why put the patient at risk of a known complication? If the risk of pneumothorax is still, maybe 1 in 100, why put the patient, put them through unnecessary risk? I think the cystic renal lesion, I really think the risk of seeding is theoretically, very low. But we do know, and there's a series at MGH, the rate of non-diagnostic biopsy is probably 50 to 75% for a very cystic lesion. So why put the patient through a biopsy if you really feel like the rate of diagnosis? Hopefully the clinician who's ordering it will speak to a radiologist who's going to do the procedure first and say, hey, I don't think I'm going to get good tissue. If it's a giant cyst and there's a nice solid nodule in there to target, I think it's fine. And then I think anytime there's any suspicion of urothelial lesions, seeding is real in urothelial lesions. In the absence of metastatic disease, I would not stick a needle into a tumor which I thought was going to be urothelial. We've seen, bad things, and I'll show you a picture later. We can look up in the kidney with the ureteroscope, so outpatient procedure, take a look in, get a brush biopsy, get some urine cytology, and there's no real risk of seeding outside the urinary tract. This is a patient one of our partners did. It has bilateral large kind of a bear claw, kind of this awful appearance of staghorn calculus. There was some hyperdense material in this kidney, and they thought it was just bleeding. But in retrospect, it was enhancing high-density material. They ended up having a PCNL, and it turned out it was squamous cell carcinoma, urothelial transformed squamous. And then this is not a stoma. This is actually tumor growing out from the body wall, which is completely awful. So, when you stick a needle through, urothelial tumor, I think you're putting the patient at risk. So I think if you think there's any suspicion, talk to the person and say, hey, can you do your ureteroscopy? If someone has metastatic disease, it doesn't really matter. Okay, they know they're going to not be a surgical candidate. They're going to need chemo anyway. This is a patient here that had a 4 centimeter, 5 centimeter endophytic lesion too, and it was biopsied outside another center. But the tumor came back as high-grade papillary, suspicious for urothelial, but we just shot a simple retrograde pilogram in the clinic, and you see that this whole upper pole is kind of not there. So I don't think this patient is 94, so wasn't going to get treatment anyway, but I've been following him for a couple years now, and he hasn't had any issues, and hopefully he won't seed that needle track, which would probably be very low, but we can easily look up or do these other kind of ancillary studies. So what does the AUA kind of think about what should be done? Well, we think multiple cores should be done. Obviously, we can't, if a tumor is 1 centimeter, it's not feasible to get multiple cores, but getting a good 2, 3, 4 cores is, preferred over FNA. We don't think, FNA is not dead. Okay? If you have a patient who has a lesion which is difficult, they're going to go for a rebiopsy. There's plenty of data that adding FNA to a core is beneficial. It could be additive. So, if there's an FNA that's done in addition, if it just enhances the maybe the benefit, but I think this is only useful for really a more complicated case or you really want to get good tissue. And I know that Doug has got the cytopathologist to come down for some cases where you really weren't sure or you're doing a second biopsy. So I think it's probably a skill which you still want to kind of learn to do well. So in terms of what should be biopsied, there's different things. It's not just black or white. Obviously, always. You think someone has like a lymphoma, it may be a metastasis, it may be infectious. Clearly, you don't want to be cutting out or ablating a tumor which is going to be a focal pylo. That's not going to help the patient. But if you have a patient who's young, healthy, unwilling to accept what the biopsy results are going to do, I would not biopsy that patient. Or the older, frail, patient who's in a wheelchair who is not going to have treatment regardless. Okay, even if the patient has a 6-centimeter tumor, if I give the results and it says it's a high-grade clear cell and the patient's not going to get treatment anyway, why subject them to an unnecessary risk? But this area, the shades of gray area, I think biopsy will have an expanding role. I think, anyone where the patient and the physician would want greater information, I feel biopsy is safe and effective. And, what can you do with a biopsy? And this is expanding what can be done. So with a fine needle aspirate or core, obviously the pathologist could just look at it under the microscope. They can do some immunohistochemistry, say, oh, it has some papillary structures. Maybe that was useful. They can give us some insight onto the renal cancer subtype. They can give us a little information on the grade. Maybe is it look cancer or not? But I can ask this question for Jeff. Jeff, Doug biopsies this for me, and these are all clear cell tumors. Which one is the one that's associated with VHL? Okay? So these are actually hereditary patients that I've seen that all have clear cell kidney cancer, that all have clear cells. Okay, and these all, probably will have differential response to having a VEGF targeted therapy agent. So just looking at morphology and the appearance of cells is probably not that useful in reality when you're looking at kind of the next generation of treatment. And maybe in the past this was really sufficient when we didn't understand so much about the genetics. But you still see, 50 years ago, people had a Grauwitz tumor, hypernephroma. Still see these occasionally on a report. But it's kind of changed from just a clear cell versus non-clear cell to now we have like 18 different types of kidney cancer, different flavors, and I'm sure we're going to have another 3 or 4 added in the next updated classification. So really, when you have a small renal mass, I don't think it's just going to be morphology and immunohistochemistry. We can do sequencing, look at the common driver alterations which may be associated with it, or then also looking at some of the changes in the copy number, gains and losses in the chromosome. And I think these are very useful for kidney cancer because you can look and there's some characteristic changes like loss of chromosome 3P, which is a clear cell tumor characteristic in 95%. There's tumors like oncocytoma, which loses chromosome 1, papillaries, which you have trisomy of 717. So you can do things like grow these tumors in culture and do a metaphase analysis, a karyotype. We do this occasionally from the OR when we're trying to look for a translocation, or you can just have the DNA look for gains and losses. And then we have tumors in young individuals that have a translocation. Translocation events are pretty common in a lot of pediatric tumors, and there are a couple adolescent and early adult tumors that have these translocations. And this is a company we're working with. They help us kind of differentiate tumors based on their cytogenetic profile. And fortunately, insurance doesn't pay for this, even though I feel like it's beneficial. So I'd like to order this on everyone, but when the patient's going to get a $600 bill, it's not going to be very happy. So mutations, obviously there are specific genetic changes that are associated with each cancer, but within each cancer there are different alterations which may have a role in prognosis. So we all have heard clear cell kidney cancer, VHL, associated with both sporadic clear cell kidney tumors and the hereditary form of von Hippel-Lindau disease. But just looking even next door to VHL, there are another 3 or 4 really kind of common genes associated with kidney cancer. And these chromatin remodeling genes, like PBRM1, SETD2, BAP1, they are all kind of associated with difference in prognosis. There's data now that PBRM1 is actually linked to response to checkpoint inhibitor therapy. If you have an mTOR mutation, you have probably better response to an mTOR inhibitor. Makes sense. So we wanted to embark on a protocol where we were going to try to have patients who were going to be put on surveillance, try to follow them over time, and link the genomic profile to growth over time, where we'd have patients who have a small renal mass that was biopsied and was found to be clear cell kidney cancer. Not every clear cell tumor is a killer. There are plenty of ones that just sit there for years, and we were trying to figure out the ones that have the chromatin remodeling genes and which don't, and really follow these patients. And when it got to a certain size and the patient was anxious, we would take the tumor out and we track their growth rate. And when you look at a linear growth rate curve, you can see there are changes. Some tumors grow fast, some tumors grow slow, and we had hypothesized that tumors that grow fast are probably going to be ones that have these chromatin remodeling gene alterations. And the trial was powered to see change in the growth rate between these class of tumors. Unfortunately, I'm the only one putting these patients on the protocol because all my partners like to cut everything out. So it's a little bit frustrating, but we have a good 10, 12 patients. It may be very hard to get to our 48. And the problem is a lot of patients don't want to undergo a biopsy if they're going to follow it anyway. And that I don't force them to get a biopsy. But in someone who's healthy, I kind of like to know what we're following rather than not knowing. And the kind of the future of localized disease is I think we're going to need an enhanced genomic biopsy where we biopsy and then we get information on the tissue. Or if we kind of develop a really enhanced or molecular imaging study, there are a lot of really exciting things. Ivan Petrosa was invited last year. They have kind of this, they're looking at a couple novel things with metabolism in kidney tumors. And obviously, our program here, we have great radiologists, to see which tumors are going to be aggressive, which tumors aren't going to be aggressive. This is really ripe to see, for the field to kind of move forward on. And I see if we kind of can predict the kind of the level of aggressiveness, we can tailor the intensity of treatment. The benign tumor, just leave alone, okay? Or if it's benign, if it becomes larger, then treat it. The indolent tumor or the more moderate, those patients, maybe they should just go for an ablation and not go through a real large operation. But the aggressive tumor, which you really are worried about, maybe you don't do a partial nephrectomy or ablation. Maybe you take that whole kidney out if it's going to be a really nasty tumor. So I think you could tailor your intensity of treatment based on really not just size of the tumor on imaging. But what about testing? Okay, this is a bill my patient had this is a really interesting patient with Li-Fraumeni disease. He had a P53 germline mutation and he got a kidney tumor. And his kidney tumor was a little funny, and I wanted to see, well, what's going on in the kidney tumor. Actually, I sequenced his kidney tumor, and it didn't have a VHL mutation, and it didn't even have the P53 mutation. It made no sense. So I actually sent him for testing, and it turned out he was a P53 mosaic, meaning he was just not P53 in his germline. It was just probably when the embryo was dividing, he had a couple P53 mutations. But we sent him his tumor for sequencing, and he got this $11,000 bill. And the hospital waives a lot of these charges, but it's not reimbursed for a lot of this fancy testing. And you really need to show that management has changed with profiling, and you need to show it's kind of cost effective. So I kind of put forth a couple protocols in our cooperative groups. We have the NCTN, the National Comprehensive kind of a Clinical Trial Network. This was a trial I wanted to do on the national level, have everyone get biopsied, and then when the tissue went, it would either get regular pathology or an enhanced genomic biopsy, and then really see, did it really change the management of the physician and the patient, okay? And this was considered not sexy. They could say, oh, we care about patients who are dying. I think avoiding treatment is a good endpoint, and the NCI cares about maybe saving lives, and I think, well, plenty of patients die during unnecessary treatment, unfortunately. The other one that I'm kind of on a smaller scale moving forward is maybe having this patient, you say, what do you want to do? Then get biopsied. Then give them the standard pathology report and say, what do you want to do? And I say, what do I want to do? And then we have, our research coordinator come in and say, hey, this oncocytic neoplasm, this is the genetic profile. This means it's really going to be an oncocytoma. What do you want to do now? Do you want us to cut out or ablate this tumor we think is benign? So I think that is going to be useful. But insurance is not going to cover these costs unless we actually show it changes management. And again, foundation medicine is a common kind of one where we send patients for tumor profiling. It's up to $4,000 per test now. And other companies, including the one I work with, it's a little bit smaller, about $1,000 to $1,500. Out of pocket might be $600. We're working on kind of more cost-effective strategies of profiling to kind of have a more targeted sequencing panel, maybe up to $10 a sample. But then once you do that, it needs to be done in a CLIA-approved lab where it's special checks and balances to make sure things are done safely. So I'm finally going to talk about really the expanding role of the interventional oncologist, okay? Where the field of interventional radiologist, where it should go. Collaboration is the key. So for the fellows or residents who are going to be leaving, find a good partner to work with. And if you don't have a good partner, if not available, choose someone like me. And Jeff has had a deal with me, and Kevin and Doug, and we've had a good relationship. So hopefully they like me. But you all share a common goal. And I think wherever you go, you understand that you're enhancing their practice. You're not stealing patients from them. There are plenty of patients who are not going to be candidates for surgery. They may be better suited for ablation. And then there are areas for collaboration. The AUA, the American Urologic Association, you think like, oh, they're against, losing patients. No, the statements are, patients, they're very good candidates for ablation. Patients just need to be counseled that there is, in reality, a higher rate of local recurrence. So if a patient's 40, you may want to say they're a little bit different than someone who's 80. And that does not mean treatment is not effective. And we try to counsel patients, ablation's great. You have to be watched closely, but you have to understand that sometimes you need to re-ablate. And I don't consider that a treatment failure, because if they still can be salvaged, it's great. Patients do have to understand that what will happen if they recur, sometimes surgery is more challenging. And the meta-analysis do show, cryo and RFA are both effective and good modalities. So we think as a field that ablation is great for small tumors. Okay, there are centers like Mayo that are doing a lot of T1B, T2A, and they say they never have a recurrence. I think a 7-centimeter tumor, if your patient is can have surgery, that's probably something that should be removed. Okay, and as a field, the urology community thinks percutaneous is less morbid, less costly. Why put someone under general anesthesia? But there are some people who are not, willing to lose their patients. And they take patients to the OR. They do it laparoscopically. We have people in the Connecticut community who still do laparoscopic cryo, and they say, "Oh, I like to look at real-time imaging." Well, I do these with Jeff, and we have the patient go in and out of the scanner every couple minutes. That's pretty real time. You don't have to look at the ice ball that carefully on a second-to-second basis. And I really think the laparoscopic approach is dead, except when you feel like you can't safely hydrodissect off the bowel. And then as a field, we think cryo and RFA are great, but these newer technologies, we just need more data. Microwave is a lot of data for liver tumors and liver lesions. As a field, we like to see more data before we adopt it. And some centers like Wisconsin, other ones are pushing real microwave. It's an ablative technology, but we like to see further data before adopting it. Obviously, people are pushing stereotactic radiation for small renal masses. Before you adopt it, you need to show it's safe and effective. And then ablation as a field, we feel you should biopsy before killing. We like to know if the tumor comes back 2-3 years later, well, if it was benign, it looks like an oncocytic neoplasm or fat poor AML, well, who cares if there's a little local recurrence that is a small fat poor AML? Now, unfortunately, urologists, when they have, just their available tools, everything, say all you have is a hammer, everything looks like a nail, then you're going to treat it. And I think, doing surgery on every small renal mass, I feel, is, you're doing your patients a disservice. But, and unfortunately, in most centers, you have this like conveyor belt. It goes to urologist, it goes to the medical oncologist, and maybe they have the patient come out and return. And I feel this does a disservice. So, I think you go somewhere, you have a nice team approach. I think Kevin has developed this well with the liver kind of folks, with Jeff, Raj, Doug, and Kevin, for these patients who try to have a more multidisciplinary approach. Everyone's a valued member of the team. It's sometimes hard to get some individuals to our tumor board, but there's a lot of communication that goes on. So for the fellows who are coming out, just find a team and work with your team, and you can have a really kind of neat, novel program where you become a destination center. And working with the team here, I think we've been able to expand. Jeff and I have do quite a bit of the ablations together. We are trying to expand to do more T1Bs. If a tumor is 5 or 6 centimeters and they're not a good surgical candidate, Well, if you're putting 5 or 6 needles in, it might be a little bit more scary, and if you bleed, you may not visualize well. So we've had Jeff do a lot of the embolizations the morning of, and then we do the ablation after. I always have to think about the timing of the biopsy, but we've had good tissue diagnosis after the embolization. And then, Kevin has similar concept for lung tumors. This idea of systemic immune therapy has a lot of toxicity. There are new agents like ipilimumab, which is approved for melanoma, which probably will be approved for a lot of other agents. Well, one is if you can deliver that systemic therapy directly to the tumor and avoid a lot of systemic response. And we have a protocol which was sitting at grants and contracts for 2 years with Amgen negotiating, but we're going to move forward where we could stick a needle into a kidney tumor that is going to go for a cytoreductive nephrectomy, and we can see if we can harness all the immune cells sitting in the tumor before just taking it out. Maybe we could treat it, stimulate the body with a systemic PD-1 agent, and then we can do maybe a delayed nephrectomy later on, or maybe no nephrectomy. And then having really ablation of metastatic disease, this whole concept of oligometastatic disease is really in multiple areas is moving forward, and it's great to radiate some tumors, but we know that some tumors with ablation of soft tissue, there's excellent results, and some patients have radiation, and they recur and they can't radiate again. So really, we've been very aggressive, and I kind of view our interventional radiology department as people who protect me from trouble. Okay, to get me out of trouble, protect me from trouble, and there's good ways to be creative and collaborative to kind of make sure I don't cause problems. So this is a patient who had a 25-centimeter kidney tumor, kidneys pulled all the way over. The anatomy is going to be crazy. Well, what's the chance I'm going to get into that SMA and I'm going to kill the patient? Well, it's possible. Well, what is if I find the renal vein first, and can I find the renal artery behind that renal vein? Can I flip this kidney over and get posterior? Not really. If you take the renal vein first and you still have inflow going to the kidney, it's going to be a problem. So a case like this, I had Jeff embolize the renal artery. So I can feel the coil, I can see what's going on, and I'm making sure I better not take that renal artery, or take the renal artery, not the SMA. There's also tumors with tremendous collaterals, and if you're not going to get that renal artery first, there's plenty of data that if you embolize before doing surgery, the bleeding is going to be less. And I have patients who, I've done that, but other patients, I just, sitting there in a pool of blood, I'm like, damn, I should have done it, because the collaterals are the size of fingers, okay? And it's not fun when you're two liters deep into bleeding and you're struggling. But also saving the day from bad urine leaks. This was, a patient, it kind of looks like a heart over here. This guy was about 25 years old, and he had this about 6-centimeter renal tumor, and he was adopted, so we had no family history. And we thought an issue was in the sidewall, but it wasn't with a very good MRI. But there's a lot of collecting system association. I actually had biopsied this, thinking it was maybe one of our rare hereditary tumors. We did a surgery, we did this open, we were deep in the collecting system. We cause a lot of harm to the kidney, okay? And I'm surprised we don't cause more things like infundibular stenosis and get into trouble. But this patient had a leak after, and we always leave a Foley and a drain, and usually the leaks get better, but sometimes they don't. This is a patient who ended up, I narrowed the infundibulum, and this patient ended up needing, you see over here, that upper pole collecting system was really not in very good continuity, this kind of narrow area. So this was one that my butt was saved by Jeff perking this upper pole, getting a nephrostomy tube into the renal pelvis. And we have another woman that is undergoing something similar now. She's VHL, she has a solitary kidney. She had 4 partial nephrectomies on the left, lost her kidney. She had 3 partial nephrectomies on the right. She had about 6 or 7 RFAs at MGH. Her collecting system anatomy is crazy. We did a partial because the 2 or 3 lesions, it was not safe to ablate, and we did not think the lesions could be hydrodissected off. She has this crazy anatomy, and Jeff saved the day again, perking, trying to dry up the kidney from abscesses, and you can do these heroic surgeries if you know you have really good backup. Now what about if I leave stuff behind, okay? You know, we like to think that we always cure patients, but, you know, as a patient with, you know, this guy had metastatic disease as well. He had we call this whack-a-mole, where you have something come up and you whack it. This guy had a lung lesion resected. It's not that uncommon. You see little nodules here in the retroperitoneum after. And this was a guy who ended up, you know, he had a hydrodissection of the colon off. He had this ablated. This guy is now, I think, 8 years out of having metastatic disease, has never seen a systemic agent, and since he was diagnosed with kidney cancer, there's 8 new drugs available, okay? So rather than him being on a therapy, having toxicity for 8 years, this whack-a-mole approach could be beneficial. But what about 2 or 3, 4 lesions in the retroperitoneum? Brad Wood at the NIH, we had a couple patients who he would wire loc. Why do you have to do that only for the breast? He wire loc lesions. We went in there. We're able to find it. You don't want to be hunting around for a 1 or 2 centimeter tumor through a guy who's tons of fat. And that type of thing, you know, is a good way for collaborative efforts. So in the last kind of a couple of minutes, take-home messages, kidney cancer is increasing. There's a lot of over-detection. I wish that, you know, the scans in the ER, we would be more thoughtful and not just scan everyone. But unfortunately, the ER, there's a lot of cover-your-butt medicine. And people are found with these tumors which probably never needed to be treated. Consider risk factors. Consider genetic testing in the certain individuals. Kidney function is important. Don't just look at creatinine. I think, you know, we should understand we really need to have really good imaging. I'm not afraid to repeat imaging study. I'm not afraid to call insurance and say, hey, these images at this hospital are really crappy. I need to repeat them here. Make sure you have the non-con phase as well. I think, you know, as radiologists, I think you need to be thoughtful and tell the doctor, hey, you're not just their technician. You have your, you know, you can decide if something is not safe. You know, clearly you shouldn't put your medical license on the line doing something which is not going to impact patient care. There is going to be a role of genomic biopsy, and I think, you know, I like to make sure that we keep Doug very busy over the next couple of years, you know, helping us try to risk stratify patients. And then wherever you go, I think partner with good medical oncologists, urologists to complement their practice. You have things that you can offer which, you know, will expand the capabilities of whatever centers, you know, the fellows end up at. And then, you know, keep your urologist out of trouble. I can't thank, you know, the guys for keeping me out of trouble and making sure I didn't, you know, cause too many issues. So, thank you. Yep.
Regarding biopsying the solid, predominantly cystic messages with small cell components, has anybody looked at aspirating the cystic components?
So, you know, people have, and the fluid usually doesn't contain like a lot of malignant cells. It's very low yield.
So I'm a big avoid the knife kind of guy, but I'm just wondering, how are patients coming to you? So how does someone end up seeing you? Are you getting referrals from other urologists who are saying, yeah, I mean, Brian's good at following these, maybe, you know, if you can follow them? Are they coming from people in communities sort of seeking you out, or sort of, you know, primary care people sending them to you, saying, yeah, this is a good one to, like, you know, how are patients being funneled to you?
So it comes in multiple. So a lot of the people in the community, the primary care doctors, I think they kind of know that we're starting to follow a lot of tumors and know that this patient who's on oxygen with a 1 centimeter mass may not be a good candidate for surgery. So I think that they're fine sending the patient to someone who's more willing to consider things like ablation and active surveillance. But I think among the urology guys, there's some who don't want to follow benign tumor or low-grade tumors or indolent tumors, so they're fine. Other people like to keep them in their practice and not even let the patient, you know, have a consideration for other approaches. So it's kind of a mix.
Are you worried that that's sort of, you know, sort of affecting some of your data because they're sort of being pre-screened by other people, which ones go to you, which ones?
Yeah, I mean, most of the pay tumors we take out in the OR now are patients who probably didn't need to have any surgery, but they're not really. It's much harder to counsel a patient about avoiding treatment. That discussion is 2 or 3 times longer than saying we're going to go treat it. And patients, you might say, this is your risk of dying of this kidney tumor in 10 years is 1%. I'm going to lower that risk. But the conversation which you really need to have is, sir, you're obese and you're smoking, and your risk of dying in 10 years is much higher. You need to cut those things out. It's a lot more modifiable for me to just cut it out or us to just stick a needle and ablate it than to tell the patient, you know, if you stop smoking today, you're going to be 10 times less likely to die than this tiny little tumor. But patients don't want to hear that.
I have 2 questions. One is active or surveillance internationally being promoted and practiced or investigated? And the second question is, so the surgical techniques, I'm sure, are better now with the robotics and laparoscopic and so on and so forth. So it's becoming safer. And ablative techniques are better now than before. And then now there are a slew of medications or medical care for chemotherapies and the targeted therapies and immunotherapies for RCC. Why the death rates are pretty stagnant on RCC?
Yeah, so I think the first question is, was it about the active surveillance? It's really nationally only about 5 to 10% of patients are going on active surveillance. The rates of surgery haven't significantly declined, and I think most people they cover their butt medicine. They'd rather treat, but it's lower than you would expect. Prostate cancer now, 50% of men don't get treated, and that's what probably should happen for these small renal masses. They should have active surveillance and delayed intervention, but it's going to take 10 or 15 years to kind of move that needle. And the AUA has really said small renal mass less than 2 centimeters, it's perfectly safe to do observation as the initial approach, even in young, healthy people. Now, we have great things. We've great fancy robots. We have great technologies to ablate. We have all these drugs. But people still die of metastatic disease. No one is really getting cured. And patients may live a year longer, but on a population-based level, if they're still dying a year later, there's still same number of people dying each year. So until we are having surgical or medical kind of cures, it's not going to change the overall population death rate, unfortunately. But survival is a little bit longer. It's probably 6 months to a year longer than it was 5 years ago, and maybe 2 years longer than it was 10, 15 years ago. But until we have, IL-2 was the only drug which was could cure people. Now with Ipi-Nivo combination, there may be some people who have complete radiologic resolution of disease. But if you take the therapy away, a lot of these therapies are not durable. And having a treatment which gives durable cure is really kind of the holy grail, and we're just not there yet in most of our cancers.
So just to follow that up, so if that is the case, does it mean that makes sense to intervene earlier upon the diagnosis, even though it's a T1A, T1Bs?
Well, if most of these people, so if you look at autopsy studies, 4% of people when they would die were found with renal tumors, some being benign or some being cancer. Nowadays, the autopsy studies, 40 years later, only 1% of people are found with a renal tumor. So what we've done is we've removed this tremendous reservoir of people who are walking normal, who have this small renal mass, which never really needed to be treated. So even though the rates of surgery or treatment have gone up threefold, you would expect if it was going to really improve, these tumors were destined to cause spread and harm, the rate of death would be going down. So the really smart epidemiology people, they say this is a clear sign of overdiagnosis and overtreatment. But they're probably the patients you find that are the 5 to 7 centimeter tumors, which it's not really increasing. Those maybe you'll be able to change the natural history. But those are a minority of the patients that we kind of see nowadays. So.
Okay, well, thank you, Brian, for a truly comprehensive talk on this. Oh, one state, just a moment longer. On localized renal tumors. I think I have no questions or many questions. I'm not really sure at this point, but I really had a lot answered. And just as a thank you for, we have a gift for you, so thank you for this excellent grand rounds.
Okay?
You.
Appreciate it.
Okay.